Welcome everyone. This is a follow-up questions that we received from our audience back in the webinar Mapping Value for Many on Precision Medicine, hosted by HITAP Thailand and the Swasri Hawk School of Public Health, National University of Singapore, and featured by our guest lecturer, Assistant Professor Wenjia Chen, on 22nd of June 2023. And these are the answers to your questions. Methodological challenges with economic evaluation of precision medicine. When conducting a health technology assessment study that compares precision medicine to standard treatments, what specific considerations should be taken into account when determining the input parameters for constructing the HTA model?
Well, thank you for this question. There are actually many methodological challenges and recommendations in constructing an HTA model for precision medicine. We have even published a paper just to summarize the challenges, and which is recently published in Value in Health. But long story short, one thing we need to keep in mind that the model should be designed in a way that it can derive the incremental effectiveness and, of course, and cost of individualized care that are enabled by the precision medicine in a consistent and unbiased manner. And we are currently developing a methodology reference case to standardize the conduct and report of economic evaluation specific for precision medicine across different developmental stages. And hopefully this will be helping the researchers in considering the input parameters for the HTA model of PM. And we will share with you the results once it's finalized, piloted, and published.
In your expert opinion, do you believe it is appropriate to utilize a healthcare perspective in the evaluation of precision medicine interventions? Could you elaborate on this, including the challenges associated with using a societal perspective?
Although ACE Singapore recommends to use a healthcare systems perspective, and it does not require a societal perspective, yet for the long term and in particular the intergenerational effect that can the precision medicine bring forth to the population, sometimes it's the use of societal perspective can more comprehensively capture such benefits, such as the human capital gains and work productivity gains. So I would say a societal perspective may be more comprehensively capturing the effect of precision medicine that extends beyond the current period of treatment, compared to a healthcare systems perspective. But of course, the use of a societal perspective is associated with its unique challenges. For example, it's sometimes difficult to capture these type of a productivity gains, or even it may not be even relevant for some target population of the PM intervention, such as the critically ill patients with late-stage cancer. And many PM studies, they are actually small pragmatic trials, which means that it's more difficult to measure productivity loss directly.
Considering the countries have varied approaches to adopting thresholds for cost effectiveness, such as Thailand's deviation from the one-time per capita GDP per QALY, could you kindly explain whether your study results and conclusions would remain consistent when using different threshold references with a lower or higher CET values?
Yes, if we use a different cost effectiveness threshold value, that may cause a slight variation of our results than what is currently we decided to use the one-time per capita GDP as the willingness to pay threshold, so that we can relate the value for money of PM to each country's unique country income capacity. And this is actually recommended by WHO for low to middle income countries. But this is not a recommendation that we will make for researchers to conduct cost effectiveness analysis. It is just for the ease of conducting meta-analysis on this specific topic, which is usually adopted by different cost effectiveness analysis of the different meta-analysis of cost effectiveness studies.
How would you address the significant uncertainty surrounding the incremental effectiveness derived from early EE or early economy evaluation results in meta-analysis and meta-regression analysis?
Yeah, in our reference case, we also have made specific recommendations for handling early stage economic evaluation. But how to address for uncertainty in early economic evaluation is a case by case, we need case by case solutions. But in general, the best strategy is, of course, to use reliable data. But in the absence of reliable data, we need to rely on an approach that require less intensive assumptions. And one can apply like comprehensive sensitivity analysis, scenario analysis, and so forth to examine the influence of uncertainty. So it may be difficult to control for uncertainty, but there are different approaches to examine the influence of uncertainty on the results. So to know better the uncertainty, to reduce the uncertainty in the findings. And also there are new advanced approaches that can rely on less or fewer number of assumptions. And we can also use reference case to present the results to increase the comparability of results between studies. Yeah.
Budget implications of precision medicine. How can stakeholders be persuaded that precision medicine is a promising intervention for reducing healthcare costs, particularly in low-middle income countries where budgets are limited?
Thanks for the question, but I personally do not think that we should persuade the stakeholders about whether PM is a promising intervention that can lead to reduced costs, because whether it is true or not a statement, we need to conduct evaluation to prove it. So I think going back to the purpose of our study, we should standardize the conduct and report of PM evaluation to better convince the stakeholders that the results about the cost effectiveness profile of a new PM intervention is reliable and reproducible and comparable with other new health technologies. Yeah. And developing a specific reference case would definitely help in this regard, in particular for the economic evaluation that is conducted in lower to middle income countries.
Your study revealed that studies funded by private or for-profit entities demonstrated higher value for money. What recommendations do you have to mitigate bias in privately funded studies? Which methodological aspects contribute most significantly to the increased value for money in these studies?
Again, it's very necessary to use consistent and unbiased method to evaluate precision medicine, and we need to have a we need to have a consensus of how we should perform and report the economic evaluation of precision medicine to minimize the room for potential study manipulation. We have, from our meta-analysis work, we have already observed that there are potential rooms for study manipulation. For example, for PM intervention with relative less favorable cost effectiveness profile, we observed that some of the key value drivers are are related to the methods that researchers chose to use, such as the choice of study perspective and even the specification of model types. Markov, like a more complicated model, will lead to a less favorable cost-effectiveness profile than less complicated model. But it doesn't mean that the increased value for money in these studies are because of the methodological specifications. It could be also possible that the negative studies funded by for-profit entities may be less likely to be published. So all in all, to conclude, we think that it's important to standardize the method to conduct and report the economic evaluation of PM.
It is intriguing to observe that stakeholders prioritize budget impact over clinical effectiveness and value for money. Could you provide an explanation for this cautious approach?
Yeah, I also find this to be intriguing, but in fact, it's not surprising at all, right? Because we are all living in a world with limited resources, and it's always important to keep investment under budget. So for decision makers, they prioritize budget impact over clinical effectiveness. I believe it's something that is certain out of all the uncertainties, that budget impact is the concrete figure of money, whereas clinical effectiveness and value for money, these metrics are associated with certain type of uncertainty there.
Yeah. On using NMB over ICER for meta-analysis of precision medicine, could you please explain why the final outcome of a precision medicine study is typically presented in terms of net monetary benefit rather than incremental cost-effectiveness ratio?
Yeah, thank you for this question. I have to clarify that we do not make any specific recommendation of using net monetary benefit over ICER for the economic evaluation of PM. And when we were searching for the cost effectiveness studies on the topic of PM, a lot of them are actually reporting incremental cost effectiveness ratio. We converted ICER into net monetary benefit just for the ease of, for the purpose of this systematic review and meta-analysis. Because net monetary benefit, it follows the central limit theorem. So the endpoint is normally distributed, whereas ICER is a ratio that is not normally distributed. So we chose NMB because it's easier for us to conduct meta-analysis to summarize the NMBs compared to ICER. But it doesn't mean that we should use NMB for the economic evaluation of PM. Yeah, it's just for the purpose of this study in specific.
Drivers for value of money for precision medicine. Is it the ISA, the cost of precision medicine, or the fiscal space of the public payers that primarily drives the underutilization of precision medicine?
Well, economic barriers is one of the important reason for the underutilization of PM, and all these aspects, they are actually interrelated with each other. We may be there may be a general lack of clinical implementation piloting and subsequent economic evaluation, which is maybe one of the major reasons that the public payers, they're concerned about the clinical effectiveness and certain costs and benefits of the PM, which can all lead to an underutilization of PM. Yeah, but in general, it is the lack of clinical implementation and evaluation, and among a lot of other reasons. So HTA is there to help to reduce these type of uncertainties and to support public payers' decision making.
Could you please elaborate on the essential value drivers of genetic tests and provide further clarification?
So the term essential means that we identify those value drivers from machine learning algorithm, and a typical like a outcome for like a when we are using machine learning based algorithm. Sometimes we call the key like a the selected predictor to be essential features. That's why we use the term essential. In short, we have performed meta regression on approximately like a 25 to 30 covariates that we think may explain the source of heterogeneity in the value for money of precision medicine from our systematic review. And we performed a lasso, one of the panelized algorithm, to identify the key predictors that are directly explaining the variation in the value for money of PM across different studies. And we found that for a genetic test, incremental effectiveness is the one and most important value driver value driver, but also for PM test with less favorable cost effectiveness profile like prognostic test. Sometimes the model specification, the choice of study perspective can affect it. And but on the other hand, for gene therapy and like a therapeutic PM, immunotherapy, gene therapy, in fact, the incremental effectiveness was not one of the major determinants of the value for money. Rather, it is the study perspective, whether the study used a societal or healthcare systems perspective, and also it is the cost of the treatment that is driving the value for money of therapeutic PM.
Why does pharmacogenomics demonstrate the lowest R2 among the value drivers, and what are the implications of this observation?
The current identified potential sources of value heterogeneity from our study only explain about like 1/10 of the R squared, or like a variability in the cost effectiveness profile of pharmacogenomic tests. This is because although we try hard to get as many variables as we could, but we are unable to get like every potential explanatory variables. So if the current covariates are unable to explain the majority of variability in the value for money of pharmacogenomic tests, that means there are also unexplained heterogeneities, and which we don't know what are they, but we believe it could be related to the disease burden itself, and it may be related to the cost of the treatment. And currently, we cannot separate the cost of treatment from the cost of test, and separate the cost of treatment from like the incremental test, because sometimes the pharmacogenomic test just goes with treatment to be like a unit cost.
Other related. Are there any examples of cost-effective studies in any countries that utilize genomic screening to identify high-risk groups for diseases like cancers, cardiovascular disease, or non-communicable diseases, and subsequently provide recommendations to mitigate risk behaviors for disease prevention within the framework of precision public health?
Well, we have reviewed like 275 economic evaluation studies on precision medicine, and I have seen that there are screening tests for identifying high-risk groups for like a cancer, and for different type of like chronic conditions like cardiovascular disease. But whether these studies subsequently make recommendation for mitigating risk of disease prevention, we did not dig very intensively into these particular aspects. And I will encourage the audience to carefully read through our list of selected studies once our meta-analysis and systematic review is published, to identify these type of studies and see if they have made specific recommendation on that.
What has been done by Singapore and Thailand to evaluate challenges with health technology assessment or precision medicine?
What has been done, like I'm sure you are aware of the recently HITAP, Dr. Yard and US, me and Wang Yi, we have published a paper just to summarize the methodological challenges in performing economic evaluation and HTA on PM. And the paper was published in Value in Health. So it's a collaborative work between HITAP and NUS. We have reviewed like 275 economic evaluations from a candidate pool of like over 4,000 studies, and we also review 40 methodology papers. So all members of HITAP, like DIMPO and NUS, we are actively involved in the process of reviewing these many studies and work together to generate this report. And we have a continued work on developing the reference case. And recently, we also successfully hosted a workshop to discuss about the usability and a feasibility and relevance of the reference case. And for the workshop, we have invited key researchers from the 5 major clinical implementation pilot team of Singapore and a few essential PM research teams in Thailand to jointly participate in the workshop. Well, please let me know if you have any questions. I can be reachable by email.